Welcome to today's Neuropathy Association webcast titled TTR-FAP, the link between neuropathy and amyloidosis. This webinar is supported by an educational grant from Alnylam Pharmaceuticals. It's now my pleasure to introduce today's featured presenters, Drs. Matthew Maurer and Michael Polydevkis. Dr. Maurer is with Columbia University College of Physicians and Surgeons, and Dr. Polydevkis is Associate Professor of Neurology at Johns Hopkins University. Dr. Polydevkis will begin the presentation.
So what is peripheral neuropathy? Peripheral neuropathy is one of the most common neurological disorders in the United States. It conservatively affects 20 million people, and the term peripheral neuropathy refers to damage of peripheral nerves in the body. The nervous system is divided up into halves. The peripheral nervous system concerns nerves in the arms and legs and trunk. So basically, everything besides the brain and spinal cord. And symptoms of peripheral neuropathy tend to vary depending on the type of nerve fiber that's been injured, but symptoms include numbness, tingling, burning, or weakness. And the pattern of involvement is typically what's called length dependent. So that means that the longest nerves in the body are affected first, and it's not just the longest nerves, but it's the ends of those longest nerves. That happens to be the nerves that extend from the back to the feet, and that's why most people with peripheral neuropathy develop symptoms in the feet and toes first. And peripheral neuropathy can affect different types of nerve fibers. So when motor nerve fibers are affected, people experience weakness. When sensory fibers are affected, people can experience numbness or pain. And autonomic nerves refer to properties that we typically think of as automatic, body functions that we typically don't give much thought to, such as heart rate or gut movement or sweating. Those are all examples of autonomic nerve functions, and those capacities could be affected with autonomic nerve involvement. So what causes peripheral neuropathy? So there are many different causes, but it's fair to say that probably a third or more of patients with peripheral neuropathy have diabetes. And it's been shown that up to 60 to 70% of people with diabetes will eventually develop neuropathy. About a third of patients have idiopathic neuropathy. This means that they have neuropathy, but we don't know exactly the cause. There's obviously a cause, we're just not able to identify it. And the other, roughly one-third of patients with peripheral neuropathy have a range of causes. There can be infections such as HIV, Lyme disease, or reactivation of infections like shingles, just due to the chickenpox virus. There could be autoimmune illnesses like lupus or Sjogren's syndrome. Cancer can be associated with peripheral neuropathy or cancer treatments. Some chemotherapy agents can cause neuropathy. And of course, there's toxins, the most common being alcohol. And they're genetic or hereditary causes of neuropathy, and this would include familial amyloidosis. So what is amyloidosis? So there's different forms of amyloidosis, but familial amyloidosis is quite rare, probably about 50,000 patients worldwide. Most of those have familial cardiac involvement, and about 10,000 are believed to have familial amyloid polyneuropathy. Amyloidosis is caused by abnormal deposition and accumulation of protein in different body tissues. Amyloid deposits cause disease by accumulating within the tissue and ultimately disrupting normal cell function. So the picture to the right is not a picture of my office, but it's a picture of someone's office that has too many books. So books are a good thing, but too many books cause problems. And in this instance, you can't even get around this person's office because there's too many books. So in essence, that's what amyloid does. You can have too much of what can be a normal thing, and that accumulation or hoarding of that protein can lead to dysfunction. Not all proteins, but many proteins have the capacity to form amyloid, and these proteins are referred to as precursor proteins. So, what is transthyretin? Transthyretin is a normal blood protein. Everybody has transthyretin. It's made in the liver, and it serves several important functions. It transports thyroid hormone and vitamin A. And in fact, that's where its name comes from. Trans is for transporter, thy for thyroid hormone, and retin is another name for vitamin A, so transthyretin. Not all proteins form amyloid. As we said, there's probably about 30, but transthyretin, or TTR, is very good at forming amyloid. It's amyloidogenic. And transthyretin itself, without any change, can sometimes form amyloid, and that's referred to as wild-type amyloid. And different proteins can form amyloid, and there's a general nomenclature. So ATTR refers to amyloid with the TTR or transthyretin protein. But things become a little bit more complicated in that if there's certain mutations in transthyretin, then it becomes more predisposed to forming amyloid, or it becomes very amyloidogenic. So this is the difference between hereditary and non-hereditary transthyretin amyloid. With hereditary TTR amyloid, there's a gene mutation in the TTR gene. There's a number of these mutations that have been identified, but one called V30M is the most common. And when these mutations occur, they make it more likely for the amyloid protein to clump and form amyloid. When this mutation occurs, it's passed on to future generations in an autosomal dominant fashion. That means any parent with amyloid has a 50% chance of passing it on to each child. In contrast, with non-hereditary amyloid, there's no mutation in the amyloid precursor protein, but the protein forms amyloid anyway. And this is what we call wild-type amyloid. In the past, it was also called senile amyloid, but that's not very nice, and it's not politically correct, so it's now called wild-type amyloid. So this is a schematic figure that I think helps illustrate some of these points. And on the far left is a depiction of the TTR protein, and it exists kind of as a four-leaf clover or a tetramer. And it's normal for this tetramer to dissociate into its singlets or monomers. And that happens in everybody at a certain frequency. And sometimes these monomers can clump and form amyloid. If it's without the mutation, that's wild type. And then if there's a mutation like the monomer in blue, then there's a real predisposition to form clumps and amyloid fibrils. So there's different categories of ATTR, or amyloid with the transthyretin protein. Sometimes the protein can deposit in the heart, and that's referred to as familial amyloid cardiomyopathy. And sometimes it deposits in nerves. That's familial amyloid polyneuropathy. And in fairness, sometimes there's overlap. So patients can have some of both. And then there's wild-type amyloid, which is not passed on through the genes or through family members. And this can cause wild-type amyloid. So TTR-FAP is a rare disease, and it affects people across the globe. Some countries have much higher prevalences of the disease, particularly Portugal, Sweden, and Japan. And presumably, this is because years or decades ago, families developed this mutation, and they stayed in those countries. But with time, they've spread across the globe, and so now amyloid neuropathy, TTR-FAP, is seen throughout the world. And as we said before, the most common mutation is this Val30Met or V30M mutation that just describes one of the mutations which increases the propensity of transthyretin to form amyloid. So I think it's important to note that ATTR is a multi-system disorder, so it affects many different organs. It can affect the peripheral nerves, the heart, eyes, or other organs such as the kidney. In neuropathy, symptoms depend on what type of nerve is involved. So typically early on, patients with ATTR experience pain or numbness in their extremities, typically their feet. They can then experience numbness and loss of sensation. So you can even have painless injuries where you can step on a painful object like a tack and not even be aware of it. Later in the course of illness, autonomic symptoms can become more prominent, such as diarrhea, sexual dysfunction, difficulty with blood pressure control. And in later stages, patients can develop weakness. This typically starts in the distal legs and feet. So there's no doubt that physicians, myself included, can easily miss transthyretin familial amyloid neuropathy. It's a rare disease, and we don't always think about it. But the clues that neuropathy, that a patient's neuropathy is not a typical neuropathy, would include the presence of a family history of neuropathy or heart failure. If the patient's neuropathy has prominent pain or autonomic dysfunction, or the neuropathy is progressing rapidly, or if early in the course of neuropathy patients develop weakness, those can all be clues that this is an unusual form of neuropathy. Carpal tunnel syndrome describes a nerve being pinched in the wrist, and that's a very common disorder, but it's seen very commonly in patients with TTR-FAP. So if someone develops bilateral carpal tunnel syndrome without an obvious explanation, that could be another clue. And autonomic symptoms, as we said, trouble with gut movement, abnormalities with sweating, heart palpitations, erectile dysfunction can also be clues that this is an unusual form of neuropathy, such as TTR-FAP. TTR-FAP can also be associated with cardiac involvement, and this is due to deposition of the amyloid protein in the heart. This caused the heart to become thicker, to have thicker walls than usual. So when physicians see this, in the absence of high blood pressure, that could be another clue that this could be amyloid as a cause. Another clue would be if there are conduction abnormalities in the heart without a clear explanation. Similarly, if there are eye abnormalities, such as vitreous occlusions. With time, TTR-FAP progresses, so typically the earliest stages, patients have pain or numbness in the extremities. Later on, they develop autonomic dysfunction and weakness, so they may require assistance with walking, braces, and at the later stages, people have trouble walking and can require wheelchair use. So next, I'm going to turn over the presentation to Dr. Matthew Maurer. Dr. Maurer is the Arnold and Arlene Goldstein Professor of Cardiology at Columbia University. Thank you.
I'd like to thank Dr. Polodeskis for that excellent setup and description of the background regarding TTR neuropathy. I wanted to spend some time talking about the patient journey through the diagnosis and management. As is shown in this particular slide, many patients have multiple different symptoms that drive them to seek medical care, usually with a primary care physician. These symptoms range from sensory or motor neuropathy, numbness in the hands or feet or difficulty ambulating, autonomic neuropathy, such that simple activities of daily living, such as regulating one's blood pressure, could be awry, and or digestion of food. They could have gastrointestinal impairment, signs and symptoms related to a heart disease, including exertional shortness of breath, effort intolerance, trouble lying flat, edema, and they may even have a kidney or ocular disease. Any of those symptoms lead usually an individual to seek care with a primary care provider who usually conducts an extensive medical history physical exam. Unfortunately, because TTR amyloidosis is relatively rare, it's often not on the mindset of both primary care providers and subspecialists. And usually any primary care provider may refer an individual for subspecialty care, either to a neurologist, a cardiologist, a gastroenterologist. And it's been my clinical experience caring for many patients with TTR amyloidosis that, again, the diagnosis often goes unrecognized for prolonged periods of time, hence the purpose of this particular discussion, to inform individuals so that they can hopefully work in concert with their healthcare providers and improve the early diagnosis. Patients, unfortunately, often are misdiagnosed with various other clinical conditions, leading to a delay, and as is shown in the middle box, unfortunately, disease progression, in which the disease can worsening neuropathy, worsening shortness of breath, a decrease in quality of life. Ideally, we're hoping for an expedited diagnosis and then an intervention and or treatment. Most interventions, as I hear about later, are there to forestall the development of progression of disease, and these fall into various categories. One therapy is a TTR stabilizer. There are two compounds, diflunisal or tafamidis, that are being either prescribed or evaluated in this particular clinical context, and certainly for patients with neuropathy. Tafamidis was approved in Europe for treatment of patients with FAP. And then there are clinical trials that are ongoing of therapies that we'll hear about later. And certainly there are conventional and supportive therapies, as well as for rare patients, the consideration of a liver transplant. And the main goal, again, is early diagnosis. Unfortunately, on the next slide, a similar story can be told for patients with familial amyloid cardiomyopathy. Again, these are alterations in the TTR protein and mutations that disproportionately result in amyloid deposition in the heart. Such individuals, again, usually develop symptoms of heart failure, that is a shortness of breath, which we call dyspnea, swelling in the legs, and abnormal heart rhythms, most commonly atrial fibrillation. Such individuals often seek care with a primary care doctor who subsequently, based on certain tests, usually sends such individuals to a cardiologist. And again, amyloid being a rare diagnosis is often misdiagnosed as either a condition called hypertrophic cardiomyopathy, thought to be due to hypertensive heart disease. The walls of the heart in amyloid heart disease thicken. The most common cause of wall thickening in the United States is hypertension, and so many individuals are thought to have hypertensive cardiomyopathy, as shown in the bottom of the slide. But in reality, one clue to the presence of amyloid is that the patient usually presents with a normal or actually a low blood pressure. Accordingly, it's hard to attribute the increase in wall thickness to the presence of hypertension when it doesn't exist in an individual patient. Again, a series of tests are usually performed, and these include echocardiograms, which are sonograms, to evaluate the structure and the function of the heart, the wall thickness, how well the heart is pumping, which is usually measured by something called the ejection fraction. Again, unfortunately, many patients with amyloid are told that the heart is pumping well, and the filling characteristics of the heart, that is the heart's ability to expand or dilate and accept blood, is impaired but often unrecognized by individuals. So if you're told that you have something called diastolic dysfunction, that is trouble of the heart filling, that's usually an early warning sign about a cardiac amyloid. Another clue to this particular diagnosis is that many patients usually receive what I would call standard medicines to treat people with heart failure. These include such drugs as beta blockers and ACE inhibitors. And while those agents are very effective for patients with other forms of heart disease, they're usually poorly tolerated by patients with amyloid. And so if you're receiving a therapy that your doctor thinks is standard and it's not agreeing with you, that's another marker or warning sign. Certainly with the definitive diagnosis is really made by a tissue biopsy demonstrating that there's amyloid in either another organ or in the heart, and then going on further to characterize that many different proteins can form amyloid, and you're trying to define that this is really TTR amyloid. That requires usually either some special staining, which we call immunohistochemistry, or further evaluation of the type of protein with a technique called mass spectrometry, which is really the gold standard. And it's important to be seen at an amyloid center that has enough expertise to adequately type the amyloid and make sure that the correct diagnosis is arrived at. Notably, I would just comment there's an emerging scanning technique, which is noted on this particular slide, which is called DPT or PYP. These are particular scans that are available at amyloid centers that are highly specific for diagnosing TTR amyloid in the heart, and are as an emerging non-invasive approach that may have a lot of clinical utility to both expedite the diagnosis and for early diagnosis. I'd just like to review with you a case history of two individuals, interestingly, who are monozygotic twins, obviously carrying, in theory, the same genetic material, because they're monozygotic twins, who had markedly disparate courses. These are two sisters of Ashkenazi Jewish descent who were born in New York City in 1947. This is a report that was published by our institution along with colleagues from the Boston University Amyloid Program, where these two individuals were provided care. Their father actually reported trouble with his feet, and there was actually 6 years difference between the presentations of these two individuals, which we've labeled here Twin A and Twin B. Twin A, as you'll see, had minimal disease monitoring and management for the first 5 years. There was really, unfortunately, no suitable treatment, but had a tremendous burden of disease and ultimately succumbed to the condition, where Twin B, surprisingly, had a significant delay in the diagnosis of 10 years, but the burden of the disease is quite low and quite distinct from her sister. Well, that is shown on these particular slides, in which we represent here the clinical history of these individuals dating back from 2004 to 2014, over a 10-year span. As you can see in Twin A, she presented with impaired vision back in 2004, had some numbness in her feet in 2005, and had the diagnosis of amyloid made on ocular tissue, vitreous tissue from her eye. Unfortunately, it was still several years later, in 2008, in which the diagnosis was further confirmed to be related to TTR amyloid, and clearly a mutation in the TTR protein called LYS35THR was identified by genetic testing. As you can see, she had a progressive sensory motor neuropathy. She had decreased sensation, initially distally, that progressed. She was subsequently unable to stand and ambulate very well, and over time even developed cardiac involvement with a pretty significant heart failure, and that's when I came to meet her. Notably, this particular individual was quite astute, sought out expert care, and was one of the individuals who was enrolled initially in the diflunisal trial. Diflunisal is a nonsteroidal anti-inflammatory agent analogous to drugs like Motrin that has been shown to slow the progression of disease. For those of you interested in the academics, the article was published last Christmas in JAMA, but showed that diflunisal taken at 250 milligrams twice daily slowed the progression of disease. And it's a participation of an individual such as this who provides us with further scientific discoveries that can help other individuals. This particular patient I had the privilege of caring for, and again developed, in addition to her significant neuropathy, with further difficulty ambulating, as shown here, unfortunately developed neurogenic issues with her bladder, leading to an inability to empty her bladder, and as a result, recurrent urinary tract infections. She also developed cardiac dysfunction and a thick-walled heart, as shown in this particular picture with concomitant atrial fibrillation. And unfortunately, drugs such as diflunisal or nonsteroidals are poorly tolerated by people who have heart failure, and the drug needed to be discontinued. Her course, as shown here over a decade, unfortunately led ultimately to her succumbing to this particular condition in 2014. That should be contrasted with, again, her sister, who is identical. And again, as you can see, there's a kind of a markedly different course. And we who take care of individuals with amyloid understand the concept of heterogeneity, that we should treat each individual as an individual, recognizing that the disease manifestations are markedly disparate. And this particular case study illustrates that. Here in 2004, this particular individual had some right hand tingling, but as you can see, there was really an absence of major symptoms that developed. In 2011, she, as her sister, developed vitreous staining that was initially negative for amyloid, although some of the pathological appearance of the fluid from the eye was strongly suggestive, this lattice-like appearance of amyloid. And I think individuals should be aware that Congo red staining, while the initial diagnostic test for amyloidosis has been around for decades and has some degree of institutional, if you will, specificity. That is, you have to be cautious about making sure that the slides are being read by a pathologist with specific and particular expertise in the management and evaluation of people with amyloid. Notably, she had subsequent tissue obtained from a fat pad. This is around your belly button. A small needle is placed in aspirated fat, and the diagnosis of amyloid was confirmed. Quite disparate from her sister, however, she has a minimal sensory-motor polyneuropathy, very, very little involvement, very, very mild diastolic dysfunction, that is mild cardiac involvement. And so the clinical course of her sister has been markedly disparate, just even though they share the same genetic information. And accordingly, it's quite clear that we still have a lot to learn about the progression, if you will, of TTR amyloid neuropathy. Again, depending on the symptoms that a particular patient experiences, they will seek care with a particular specialist, as outlined here. Usually they initially see their primary care physician, but based on particular symptoms, they may be referred for a cardiologist for heart failure, neurologist for the neuropathy, a hematologist who's often involved really in the care of individuals who have a different form of amyloid, that is AL or light chain amyloidosis, which is caused by a protein produced by blood cells. And one of the key issues in amyloid management is to correctly arrive at the appropriate and accurate diagnosis, that is, which protein in the body is causing amyloid deposition. And some individuals need to see a nephrologist or urologist for management of urinary tract issues. Again, I think there are key points that one wants to take away with regard to the accurate diagnosis. For familial amyloid polyneuropathy, certain red flags that should raise the specter of this diagnosis among clinicians are what we call a length-dependent progressive sensory and motor polyneuropathy. What that means in English is that from your distal toes, you begin to develop a burning sensation in your feet, and over time, the sensory abnormalities progress proximally upwards the feet and the hands, ultimately also developing motor symptoms. Individuals can have what we call orthostatic hypotension. This is a drop in one's blood pressure when they stand up because the autonomic nervous system is being damaged by the amyloid and can't regulate one's blood pressure. There could be urogenital symptoms, including in young men, early erectile dysfunction, and in both men and women, urinary incontinence. Your gastrointestinal motility and the ability to digest food is, again, part of the autonomic or automatic nervous system, and that particular regulation, when awry, results in altered bowel habits such as constipation and diarrhea. The latter actually could be quite disabling to individuals. Often in the latter phases, they're afraid to leave the home because of concerns about fecal incontinence. Unintentional weight loss pursues, unfortunately, and cardiac symptoms also can develop. And all of these should highlight in a clinician's mind the diagnosis that could occur. Diagnosis requires a biopsy of tissue demonstrating essentially amyloid deposition, and then ideally that tissue and that amyloid is due to the transthyretin protein. And in order to confirm the diagnosis of what we call familial amyloid polyneuropathy or familial amyloid cardiomyopathy, i.e. one that is inheritable, you evaluate the TTR gene. This is done with a simple blood test. The gene is sequenced, and we try to determine and do determine whether or not there's a mutation in the gene that leads to the manifestation of the disease. This condition is inherited in what we call an autosomal dominant fashion. That means if you're affected with this condition, any first-degree relative has a 50-50 chance of inheriting the condition from you and potentially manifesting the problem. If you and your family are experiencing any of the symptoms that we've been talking about today, I think early diagnosis is critical. And it's critical because all of the therapies that are brought to bear at this point in time, either that have been proven or that are experimental, are all there to prevent further amyloid deposition. They don't remove amyloid from the tissues at this point. And so early diagnosis and preventing the damage that we talked about in the heart and the nerves and the intestinal tract is important. It's critical for you to be an advocate for your own health care. You should obviously inform your clinicians about the various symptoms that you're having. Certainly, if you feel like you're not getting an appropriate response, I strongly encourage individuals to get second opinions. Genetic testing is penetrating modern medicine, but many clinicians are not trained in that. The testing itself is very simple to do. Is done by several national laboratories and either requires a blood sample or a sample of saliva. And there are assistance programs shown in this particular slide that allow individuals to access genetic testing and get the workup done with support so that the out-of-pocket costs are minimized. I think there are many things that you can do to impact if you're diagnosed with TTR on your daily life and with regard to how it affects the quality and quantity of your life. Obviously, share your diagnosis and your feelings with those who you love, those who care for you, your family. It does require quite a bit of support. You should obviously let them know that they're as well, unfortunately, at risk, which is a difficult thing to discuss. And if you're having trouble revealing that, clinicians, particularly genetic counselors, can be quite helpful in helping you explain the risk to family members and having them be identified with the condition prior to its manifestations. There is actually a National Society of Genetic Counselors, and you can visit their website for further advice and access. There are multiple wonderful support groups that have been developed by patients and family members and caregivers of individuals who suffer from amyloid, and those are listed here, including the Neuropathy Association, who's been involved in putting this program together. It's quite important for you to be a strong advocate, understanding your symptoms, describing them clearly and concisely to your healthcare team, keeping a record of what various clinicians are saying, and serving as the strong quarterback certainly helps in advancing your care. Many centers of excellence have specialized programs that can provide you with access to the latest research in the field and access to advancing clinical trials. Unfortunately, in the United States, there are no FDA-indicated therapies for transthyretin amyloid. Tafamidis is an agent that was approved in Europe but not in the United States for FAP. Obviously, diflunisal, which I mentioned previously, is a nonsteroidal that is available by prescription from certain providers. And again, you have to have an appropriate conversation with your clinician to determine whether or not it is a safe and effective therapy dependent upon your manifestations of amyloid. The prognosis in the literature is usually that survival is about 7 to 10 years after the initial manifestation of the disease, but it's often difficult for patients and clinicians to identify when the disease actually began. Many of the symptoms are relatively nonspecific: fatigue, effort intolerance, and it's very difficult retrospectively to know exactly when the disease started. survival in large series have been dependent not only on the age of the patient, with younger people doing better than older, women, interestingly, doing better than men, and the particular genotype, but it's most dependent upon how severely affected various organs are, i.e., early diagnosis being the key. For example, at our institution, where we care for a lot of individuals with advanced cardiac amyloid, the survival is shorter than reported in the literature, on average 3 to 5 years after presentation. There are certain heart blood tests, and these are called cardiac biomarkers, particularly things called troponin and BNP, that are useful for not only staging the disease, finding out how advanced it is, but also for monitoring disease progression over time, which occur in concert, obviously, with the patient's functional capacity, what they're able to do on a daily basis, how far they can walk, and based on the patient's signs and symptoms and physical exam. Again, I can't emphasize enough how important self-care is. You want to be organized if you can, facilitating the interactions with your clinicians, having a list of the medicines written out, even if they change over time, including the name, the dose, the route, and how often you're taking such medicines. It's always helpful to prepare a list of questions prior to the interaction so that you make sure that you have all your questions answered. I always tell my patients, though, if we don't answer a question, feel free to contact our offices, and I'm sure other clinicians feel the same way, and ask your questions. It's very important that you have a clear sense. Some patients are asked, especially those with heart disease, to weigh themselves on a daily basis, and even in some individuals, recording blood pressure with automated cuffs can be important. For patients with cardiac involvement, the mainstay of therapy is diuretics. When the heart is unable to deliver enough blood supply to the kidneys, the body becomes very salt-avid. You retain water, you become swollen and edematous. And various diuretics, particularly ones that are what we call bioavailable. That means when you put them in your mouth, they get absorbed, particularly bumetanide and torsemide are preferred forms of diuretics, because as your legs get swollen, so does the wall of your intestinal tract, and that can impair absorption of medicines. Certain heart rhythms, particularly a rhythm called atrial fibrillation. The atrium is the top part of the heart, and when it fibrillates, which is a Latin word for dancing, you lose the coordinated activity of a normal heartbeat, and that's very poorly tolerated by patients with amyloid whose hearts have trouble filling to begin with and really prefer to be in a normal rhythm. As I mentioned, many standard medicines that are used to treat patients with cardiovascular disease, particularly a class called beta blockers or another group called ACE inhibitors, in my experience, are quite poorly tolerated by patients with amyloid, and this is one of the clinical clues, i.e., if you're being prescribed these medicines and you feel absolutely miserable, you should, and clinicians should think that the diagnosis of amyloid is possible. Over time, besides affecting the muscle of the heart and thickening, the amyloid can infiltrate the electrical wires in the heart and ultimately result in a need for a pacemaker. In our experience, again, in patients with familial amyloid cardiomyopathy, the need for pacemakers is about a third of patients over several years. In selected individuals, liver transplant has been performed, and the theory here is that the transthyretin protein that is mutated and abnormal is made by the liver. So if you transplant one's liver and replace it with a liver that doesn't make that mutated protein, in theory, you would arrest the development of the disease. And this has been done for decades, particularly mainly in Europe. This is a form of therapy that is usually restricted to patients with very early disease, because you have to be healthy enough to withstand the surgery of a liver transplant and be able to take the immune suppressive therapy. Unfortunately, what we've also learned is this particular therapeutic intervention is not terribly effective, and the disease can continue to progress, in part because normal TTR, we call that wild-type TTR, can also misfold, that is transthyretin, and contribute to the development of amyloid. So even though you've replaced your liver with a normal liver that's making normal protein, in certain individuals, the disease actually progresses faster, for example, in the heart, after a transplant than before. And so clearly liver transplantation is a no panacea, and certainly the idea of combining a heart and a liver transplant is even more risky, more difficult to come by. That has been done in very, very rare individuals, I'd say less than probably approximately 30 worldwide. And the idea here is that your heart is so affected that you couldn't withstand a liver transplant in isolation, but you receive a heart and liver transplant together in order to sustain your body. Such things are usually restricted to younger individuals who have a significant heart dysfunction and have a particular mutation that's anticipated in the future to cause significant neuropathy, but who don't currently have significant neuropathy. With the transplant information as background, it's pretty clear that we need more effective therapies. And there are several promising new classes of drugs, which Dr. Polydekis will now delineate and describe for you.
So when we treat symptoms of amyloid neuropathy, the treatment's based on the symptom. So if it's pain, we have a number of medications. They typically fall within three classes. So some antidepressants overlap and treat nerve pain. Similarly, some seizure medications treat nerve pain. It's obviously not seizures, but some of the medicines that treat seizures can also treat nerve pain. And then there's opiates or opiate-like medicines that can be very effective at treating nerve pain. And then there's a few topical agents. When the problem is autonomic dysfunction, the medicines are designed at treating that symptom. So if it's constipation, there's medicines for constipation, or conversely for diarrhea. There's a number of medicines for sexual dysfunction, particularly erectile dysfunction in men. Sometimes people with amyloid neuropathy can have difficulty with blood pressure, where their blood pressure drops, and there's medicines that can help that. And in addition, salt tablets or support hoses can help. Weakness can be a problem, so it's important for patients, especially early on, to exercise and build up strength, which will pay dividends in the future. Balance training can be very helpful to compensate for some of the imbalance that occurs. And if weakness develops, there's braces that can be very helpful in helping people walk when they have weakness. Then I think it's important to recognize that TTR-FAP is a chronic illness. Patients are in it for the long haul, so they have to help cultivate and build a support system among family and friends and keep a positive attitude. So TTR-FAP 10 years ago was a disease that we couldn't do much about, but that's dramatically changed, and I think will continue to change. So there's a number of exciting trials and treatments that exist today. So one of the treatments is currently in clinical trial, patisiran, a drug through Alnylam Pharmaceuticals. And the second drug, ISIS-TTR, a drug being developed by ISIS Pharmaceuticals. Both these drugs are designed to decrease or block TTR synthesis. So if you can't make the protein, you can't form the clumps and amyloid deposits. Tafamidis and difluzinal are drugs designed to stabilize the tetramer form of TTR, so they keep the drug in its four-leaf clover form and prevent it from forming the monomers, which can in turn form amyloid. Tafamidis is approved in Europe, but not currently in the United States. Difluzinal has been shown to slow the progression of neuropathy over time, and is available. I think it's important to note the personal impact of TTR-FAP, and this is a quote by a patient, Robert Haig, and the full story is available at the website neuropathy.org, but it describes his interest to find out more about TTR-FAP. So the quote reads, "I was on a mission to learn about TTR-FAP and fast. It is inherited in an autosomal dominant manner, meaning each child of a gene carrier has a 50% chance of inheriting the variant gene. We're a family of 5 siblings, hence the urgency to get informed and to share this news." So I think that says it very well, how this is an issue that affects not just patients, but their families. So in conclusion, I'd like to mention a resource that's available to both patients and researchers. It's called Research Match. It's a registry for patients, and that registry can then connect physicians and researchers with those patients. And you can learn more about this registry at www.researchmatch.org.
That does conclude today's presentation, TTR-FAP, the link between neuropathy and amyloidosis, brought to you by the Neuropathy Association and presented by Dr. Michael Polydevkis and Dr. Matthew Maurer. We do hope you enjoyed the presentation. For information about peripheral neuropathy and the Neuropathy Association, you can visit www.neuropathy.org. For more information about patisiran and Apollo study, visit www.apollotrial.com. To learn more about Alnylam Pharmaceuticals, you can visit www.alnylam.com. And to learn more about this free screening that is mentioned on the slide that is now appearing, and to download brochures and other forms, you can visit www.alnylam.com/patients. And you can also contact Alnylam Pharmaceuticals at 1-866-330-0326. As we end the session, you'll be redirected to the Neuropathy Association website, and we do invite you to explore the many resources that are available on that site. Today's program is copyright in 2014 by the Neuropathy Association, all rights reserved.